Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 32. Now, most of you know something about the opioid crisis, right? It's considered one of the most devastating public health catastrophes of our time. Just to summarize briefly, the first wave of deaths began in the mid-1990s when Purdue Pharma's newly approved pain drug OxyContin was pushed to doctors. Purdue had lied to the FDA, saying that OxyContin was less addictive than these other opioids. It was actually even more addictive. Then came the wave of deaths, many of those from the addicts switching to street heroin. And then, as we all know, came the synthetic opioid fentanyl. 2024 figures aren't yet finalized, but even though there has been a decline in deaths, the U.S. continues to have the highest death rate from opioids in the world. With that as the background, I just had a very illuminating discussion with Dr. Arun Gupta. He started as an internist, but ultimately he got so upset about the plight of his addicted patients in his mostly rural Michigan practice that he became a specialized addiction doctor. He wrote a book then, laying out the history of opioids and what needs to be done to help patients recover. This is a conversation. It's really, really important. I don't think you want to miss it. Arun, thank you so much for coming on the program.
Stephanie, it's my pleasure to be here today with you.
We haven't heard a whole lot about opioid overdoses. It's mostly fentanyl when we start talking about deaths from overdoses at this point. But is the opioid situation still the same thing that we heard about for so many years and that ruined so many people's lives?
So it started around in mid-90s when Purdue Pharmaceutical got OxyContin approved for chronic pain for long-term use, saying it was mislabeled, it was not addictive, not abusive, and less than 1% people had a chance of getting into trouble.
Right.
They lured hundreds of thousands of doctors into writing it in the country. And by 2010, we had about a 10% increase in overdose deaths in America. And then the government started to feel and put brakes on Purdue Pharmaceutical to make it a non-abusive formulation where it is delayed release. People can immediately crush and inject. But that really had more OxyContin available for abuse. So patients still liked it. It took a while for them to figure out. But as the OxyContin sales went down and doctors got concerned, the people started to use heroin, and the death rate went up from 10% to 15% till about 2017. And as more and more regulations were thrown at the system, the doctors and the hospitals and the insurance companies and DEA, everybody came in. And then the fentanyl started coming through China via Mexico. Initially was directly. And the last 7-8 years, 100% of the deaths are from the street fentanyl. So it's not doctors, it's not prescription medications that are responsible for this crisis anymore. We had a peak of 114,000 people dying a year after year for 3 years in a row during COVID. Last year, the number may be down a little bit to 109,000. On a cumulative basis, we have lost more than 1.5 million people in the last 25 years, young, healthy Americans without a war or a famine on our soil because there is no access to care. Doctors are not trained to provide care to these conditions.
Okay, so we will talk about that in a separate issue a little later, but I want to stick around and talk a little bit about why people get addicted. We were told with OxyContin that it was chronic pain because obviously that's why you would be going to a doctor. The wider addiction seems to be, almost everything under the sun. But is there any difference between a person who has chronic pain because of an injury or anything else and a person who may have a chronic medical condition, a mental condition, for example, or just trouble dealing with the world, or just got sucked in? I mean, is addiction addiction?
So, addiction is initially started as a genetic disease, and it is influenced by the circumstances and the situations that you are brought up, and then the lifelong experiences that people experience. So, we call about adverse childhood experiences that children experience, and that's going to determine how what kind of personality they have. And if the personality is explosive and abusive, then they're going to be easily get into trouble with the addiction, whether it's drugs, alcohol, marijuana, smoking, eating too much, all kinds of addictions. Now, these younger people are getting into addiction with the technology. They're sitting on their phones and the computers. So something is lacking in their brain, social skills, maybe lack of dopamine. All these factors contribute towards addiction. A person who is healthy mentally, physically, is less likely to get into trouble with addiction as compared to somebody who has a pre-existing mental condition. It's about two-thirds of the time they're more prone to get into trouble.
But if you are coming at it with chronic pain, you have an injury that won't go away, maybe you can't afford to get your knee replaced, whatever it might be. Is that different than, I mean, again, you're talking about people with some kind of mental issue, whatever it might be, even if it's as simple as feeling that you don't belong to a group or whatever.
So
And pain is something else again. Um, so is there a difference there, or in
the,
the end, are you treating the same thing?
the pain is not a predetermined condition that will lead to addiction. It is psychosocial in the patient's life in the brain that is going to determine whether you're going to get addicted or not. I had an injury to my finger 20 years ago. I was cutting a watermelon and the knife went through it. I had 2 hours surgery. The surgeon wrote me 10 pain pills. I didn't take any, and I suffered, and I knew I shouldn't be taking it. And I, not that I was afraid I'm going to get addicted, but I just didn't want it to have that exposure. What has happened in the past 25, 30 years is you go for a dental procedure, you had a minor surgery, people were given 25, 30, 40, 50 pain pills, and people who were predisposed to getting addicted liked the effect of it because it caused euphoria. It did take away the pain, but it caused them to feel better, feel good. And those were the people who will get into trouble who get that feeling out of it. Most people will not get that feeling and would not use it on a long-term basis.
It's interesting that you talk about your own finger and the watermelon. So I had a bunch of knee surgeries over the years, and I was always told there's a morphine pump over here. If the pain gets too bad, this was when I was in the hospital right after the surgery, you can just give it another go. And I was always deathly afraid of anything with the term morphine attached to it. So it just didn't. And I lived, you know. Um, I wonder how many people were told that in a hospital setting by a doctor who thought it was really true, and it really isn't true.
So I could tell you the other side of the story. Let's look at a patient who is in severe pain for years and is admitted to the hospital in pain or in withdrawal or requiring more surgery. The hospitals were afraid to give them enough pain medication because there is no training. So when I would go to the case, I will say, use this pump. You have limited access to it, but you could use it every 10 seconds, if 10 minutes if you want it. But after a while, it's going to shut down. So we need to provide dignity to the patients and treat them as human beings, not as junkies and alcoholics and druggies. That's
Well,
the other side of the situation.
the other side of the situation, I noticed when somebody that I knew got a knee replacement about a year ago, they did not get that morphine pump. they don't give it anymore because then maybe it's not necessary because they can put the necessary pain medications right into the knee before they close it up for the first couple of days. But
That is true.
I'm just thinking that maybe they don't do that anymore. My experience was, 10,
Yeah.
15 years ago.
So the regulation is spun in the opposite direction by 180 degrees.
Yeah.
Before we were giving unlimited pain medications, even pushing more by the surgeons, by the patients, by the providers, by the family. Hey, my person is in pain. Now it is 3 days of pain medications, 3 days of anxiety pill after any major event. So the regulations have gone in the opposite direction. We do not respect and treat people with dignity and humility, and people suffer. I give you an example. I had a lady, diabetic. She had bad circulation in the legs. Just in the beginning portion of the COVID, she had one leg amputated, and the other leg had vascular surgery all the way from the groin to the feet. She had staples in the right leg all the way, and amputation on the other leg, and she was sent home on 3 days of pain pills. She came crying to me. What I do, I said, you need to go find a pain doctor. We have one pain doctor who works part-time in our town who would not take her insurance. So I had to provide her some pain control for the next few weeks, risking my license because the regulations say, Doc, you're not a pain specialist. You shouldn't be writing these medicines on a long-term basis.
Well, how do you equalize this? I know that you want to help people. I mean, all doctors, excuse me, want to help people feel better. That's why you become doctors, to save people's lives, to correct, whatever is wrong with them. But there is this addiction issue on one side, and there is the pain on the other side. How do you balance it?
We can balance. So treating people with pain or addiction is learning how to fly a plane. There is no education how to land that plane. The doctors in America or anywhere in the world from medical school are not taught how to treat pain or how to treat addiction or how to get people pain off the pain pills. So that's a big problem. That needs to change. We have a major crisis where millions of people have died. More 30, 40, 50 million people are screaming for help and can't get help, and they're forced to go to the street. But ACGME would not start a curriculum in the medical school to teach doctors pain and addiction.
It does not seem very intelligent to me here on the outside.
Yeah, I'm on the inside. I can't convince anybody to do that. And that's why we need to join hands and forces and like-minded people. Like I've been saying for 5 years on the social media, let's make fentanyl, street fentanyl, a class 1 drug. It's a
What
very
is a
useful.
class 1 drug?
Class 1 drugs is heroin, cocaine, methamphetamine, even marijuana is class 1 from a federal standpoint. Any drug that has an abuse potential and no good medical use is called class 1 drug. Fentanyl is very useful. When you have surgery, they give you IV fentanyl. All the surgeons use it in the hospital for a quick pain relief. We used to write fentanyl patches for patients with chronic pain because the patch covers pain control for 3 days. So when fentanyl started to show up on the street as being in the drug test, we didn't know it was coming from China. We thought it was fentanyl that was locally distributed or prescribed. So we panicked. It took 4 years for the government to figure out, researchers, that it is coming illegally from China and now through Mexico. So I have been saying on the social media, I had a discussion with even the O'Neill Institute that, hey, let's make this fentanyl class 1 drug. And they said to me 3-4 years ago, it's a hoax. It's not going to work. I just had an email from Washington. There's a bill on the floor as of yesterday that let's make fentanyl a class 1 drug. So somebody's paying attention. Things need to be taken care of.
I think it's a surprise to any of us because all we hear about is illicit fentanyl, that it is a usable drug. I mean, I literally found out about that maybe a month ago when I started to do some research on something else. I had no
Mhm.
idea it was a legal drug.
Yeah.
So, and it seems to me, of course, it should be in that class one.
So, like we have amphetamine, like Ritalin, Adderall, those kind of prescription stimulants. They are class two drug, and then the opposite isomer is called D-isomer. It's the methamphetamine. So I've been saying scientifically, from a chemistry standpoint, they should be able to synthesize and differentiate the prescription fentanyl to the street fentanyl. We don't need to jeopardize the fentanyl which is being used in the hospital settings in America or around the world. We just need to label the street fentanyl and make that a class one drug. So now they want the proposal on the floor in Washington is let's make the whole fentanyl class one, which doesn't make sense to me.
Well, how can you label street fentanyl? I mean, it's illicit. It's not legal if you're getting it from the street. So, what is the purpose of labeling it anything? You just want to, stamp it out somehow.
Yeah, so what I say is like marijuana is class one drug from a federal standpoint, but legal or decriminalized in 33 states.
Yeah, right.
Ohio just approved in 34th state now. So even the laws on class one drugs are very soft in this country. So even if we make the street fentanyl class one drug, but don't control access and distribution of it, it's going to not solve the problem. So let's go to Vancouver, Canada. They 2 years ago said any addicted patient can have 2.5 grams of fentanyl possession, which is 1,250 lethal dosages. They can keep it themselves, they won't be legally charged. So people in America are saying if Canadian government is that compassionate to the people who are addicted, we here give IV heroin to these addicted people in a controlled setting. So these people are not demanding that they should have access to the street fentanyl so that they can have a better life. But it's dangerous.
I find this, again, as someone who is really sitting on the outside of all this, just very confusing. To me, it's been always black and white. If you're addicted to any kind of a drug, it's bad, and you should be off the addiction. And we put people, in hospital situations for a particular period of time to get them off those drugs that they're addicted to. So it's been that way, black or white. You're talking about a kind of a middle ground. And you're also talking about looking at people individually, I think.
Yes.
And I don't know how a country this size can do that.
Well, if we like COVID happened, we had no idea what was going on. Millions of people died in a short period of time because there's no testing, we don't know what the effect of this thing is.
Right.
We have this situation in our hands, addiction. People are dying by hundreds of thousands every year. We need to start providing proper care. We need to have doctors who are trained to do it because doctors are not being trained. They come up with harm reduction policies. There are 1 million inpatient beds in America that treat addiction. Somebody can afford a week, somebody can afford a month, somebody can afford 6 months. These people need to come out and be followed by doctors like me, which are less than few thousand, but nobody sends us patients. Nobody comes to us. And what happens when they come out of that rehab, they relapse. So it's not, if you have a sugar of 600 and you come to me to the hospital, we hang an IV drip of insulin and IV fluids and bring the sugar down, it's not going to cure their sugar. This addiction is a chronic, relapsing, long-term problem. They're going to need long-term care like any other condition. I have 85% success rate in my 18 years of experience. These people are off the drugs. They take the medicine that's FDA approved. They get back to work. They get back with families. They pay taxes. They buy houses. They buy cars. They go on vacations. They come and show me, doc, look my wallet. I have money in it. I never had it. And that's what treatment does. But it needs long-term care, not just 1 or 2 weeks. It's not going to work.
Maybe because you just said it, there are only about 1,000 of your type of doctor, pain doctors, essentially, available that other doctors don't even know about your specialty. I have heard. I live in an urban area. I mean, I live in the wider New York City area. Um, Obviously, we have every kind of doctor there is available here, but you're in a rural area. Does that make a difference?
It makes a big difference. I'm the only doctor in town who does it. But no area agency sends me patients. They just keep on keeping patients with themselves. Do a good job in providing a bed and food and some counseling services. After a few days, they go back and then they come back again a week or two later and keep on doing the same thing. My patients don't overdose, they don't die, they just do well. And so I can't showcase them because, they may not be ready to tell the public where they were, how good they're doing, because the work may not know, the children may not know, the grandparents may not know. So they keep on showing all the doom and gloom, but we need to find a way to show how good these people are doing so that others get motivated.
Let me go back to the chronic pain issue.
Sure.
I think you talked about that there are some people that basically are going to be kept on some level of an addicted drug, perhaps for their whole life, if they can't, find a medical way to get rid of the pain itself. Is that true? And are there so-called addictive drugs that are used for medical purposes that people can stay on and still have that normal life that you were talking about?
So I'm not a pain specialist. I treat people with addiction.
Right.
There is a subspecialty called pain medication, pain specialists. So these doctors were writing a lot of pain medications 10, 15 years ago. You know, pain pill for long-acting OxyContin for 12 hours, short-acting for breakthrough pain. So now what I see, because the regulations and how the DEA conducts these studies on which doctor is writing how much medication and how many milligrams they're writing. So now they're forced to prescribe subtherapeutic dosages of pain medication. The medication works for 4 to 6 hours. You need 4 to 6 a day to control your pain, but they're giving like 2 pills a day so that their doctor numbers are low. We've been forced to send patients to the street to get pain control because I don't want to lose my license. I don't want to go to jail. I don't want to be humiliated. I don't want to become homeless taking care of these difficult patients. So we are abandoning compassionate care to the patients, to their needs, because of the regulations are wrong.
Are these regulations all federal or are they also state or is it mixed?
Oh, it is federal, state, DEA, insurance companies, pharmacies. Everybody has their own regulations piled on top of more regulations.
Well, that
So
makes it much more complicated to straighten out,
yeah.
obviously.
So
Well,
what they do it is they pass a regulation, nothing happens, and then they come a week, a month later and pass more regulations. I give you an example. 6 years ago in the state of Michigan, our government changed. So the new governor comes in and she signs in a law and says gabapentin, I don't know if you heard the name or not, or Neurontin is a Schedule 5 drug in the state of Michigan. Now, this is at the peak of the opiate crisis.
mhm.
So I started talking to people in licensing and regulation, the medical examiner, and some politicians. And I said, why did this happen? It's not, federal government says it's not a scheduled drug. How is it going to help the situation? So I was explained two things happen. Gabapentin is the 19th drug of overdose. So they check for 20 drugs, and it's the 19th drug.
What
And
does
that's,
it do? What does gabapentin? I know the name, but I don't know what it does.
well, it's used primarily in the space for chronic radiculopathy pain. You have pain from the neck to the arms, legs going down, those kind of pains. It's been used for a lot of good things, a lot of conditions, anxiety. People use for if I have to detox somebody of alcohol or benzodiazepines, I use it for that reason. It's used for seizures, it's used for mood disorders. So it's used for a lot of different things by different specialists. And the second reason they said it is because when they do autopsy on people, gabapentin was in their pocket. Okay. So if it is a 19th drug and people are not dying as the first three, four drugs, it didn't make any sense. The medical literature did not support it. So when I wrote the book, I wrote a whole chapter on this saying it was not necessary. So 3 years ago, when my book came out, our attorney general was in our town. We had a town hall meeting, and I spoke and she spoke, and I gave her the book. Guess what? 6 months ago, that law got reversed in the state of Michigan. So people are paying attention because these knee-jerk reactions are making things worse, both for the patients and for the doctors.
All right. Can you, we've been kind of talking around the issue. Tell me specifically if I am either addicted to a drug for whatever reason or because I have chronic pain and will always need some help with that, what is actually legally available for me no matter what state I live in?
So you start with Tylenol, acetaminophen, which is over the counter. Then you go to Advil type medications or prescription ibuprofen or naproxen. And then it is Tylenol 3, Tylenol 4, Vicodin. Those are prescription medications, the last 2, 3, 4. Okay. So your question is, what is there to do for patients in chronic pain?
Legally,
so what
under
happens
the
in
laws
my practice?
we have.
Yeah. So what happens in my practice is I get a patient says, I had this surgery, I had that surgery, I cannot do this, this, this. I'm in pain. I was getting this medication from this doctor. That doctor went to jail. I can't find anybody to write my medication. How can you help? So this person is in pain and they are in withdrawal. So that makes two problems. So the buprenorphine or Suboxone is only approved for treatment of addiction, but is also being studied. My office is one of the centers with the University of Michigan to see if Suboxone would work for chronic pain. So I have a lot of patients.
Could you say that drug again slowly? Because
it's called Suboxone, Suboxone. The generic name is called buprenorphine, Buprenorphine. It is taken sublingually under the tongue till it dissolves. And for addicted patients, they usually take it once a day. For people with pain, we give them small portions every 4 to 6 hours or 6 to 8 hours, and that controls the pain. So I have transitioned quite a few patients from methadone or heavy-duty narcotics to Suboxone, and it's legal to do it, and it takes experience and knowledge to do it. And so I have quite a few patients who come to me to get off the pain pills and just stay on a safer drug that is not abusive or addictive.
So it is possible then to have something that will help you for the rest of your life and not be essentially addicted.
Yes, that is true. This medicine is not addictive. There's a new medicine that has been approved recently. I think it's called Jonarex, and it works at the chloride ion channels. It's not, I think, still not available, and would decrease the sensation of pain at the cellular level. But you're going to need an army bigger than Purdue Pharmaceutical to promote that. Doctors don't know about this medication. I know it because I'm in the space looking for what's going on at a national level. You've heard about it. And so if this is available in 3 to 6 months, let's say, for example, the only way you would do it is you will have to go educate your doctor and say, hey, can you look this up and see if it is safe for me to use it? There are some side effects that have been listed, muscle spasms and a rash and that kind of stuff. But it's twice a day medication, and it may work for moderate pain, surgical post-op surgical pain. They've studied in people with um, abdominal surgeries and foot surgeries, which are kind of painful situations. So it's a good thing that we have another agent that could be used for short or maybe longer period, but it's not been studied for more than 2 weeks. So we do not know the long-term implication, like 3 months or six
Right.
months or a year.
Right.
So does that answer your question?
Well, sort of.
Okay.
I
All
always
right.
have the sense when I'm talking about medical issues that as we speak, something else is coming into the pipeline that we don't know
Yeah.
about.
Yeah.
But you you have written to me anyhow, like if I had a college course talking about general health, social health issues, your book would be the first one I would assign students because it's written in English. It's not written in doctorese. And everyone can understand it, and it has such a good history of all the things that we've been talking about. But you also say in the book that it's that the problem that we have with addicted people for whatever reason can be fixed. When you talk about fixing, what exactly do you mean?
Well, you could start with prevention in lower grades, which we work through the Rotary system, and a lot of local communities are trying to educate the younger students about it. We can have better education on how to promote counseling and therapy for these addicted people. Right now, majority of the counselors are not addicted, trained in doing addiction counseling. We need to train doctors so that they can take care of these addicted patients. So the whole thing has to change. In my practice, with this Data 2000, the law that was passed into year 2000, it allowed any doctor to take a course, pass an exam, apply for an XDEA number, and that's how I started learning addiction. But I found a lot of problems in the system that I ended up writing a book. So as of today, less than 7,000 providers, that's doctors working with nurse practitioners and physician assistants, participate in providing care to the patients with addiction. Even though more people have been credentialed, but most of them do not participate in that. So we have to broaden the base, improve the access to care, and then tell the patients and the families and the media, hey, treatment works, it's available, go see the doctor. So I say in my book, and otherwise in my presentations, let's say somebody calls 911 for an overdose. The cop goes there, the ambulance goes there, the fire truck goes there, they give Narcan, they revive the patient, and then they leave. Okay? Or if the patient doesn't get revived, they're brought to the hospital. I'm saying, why don't we give them 3 days of medicine that I would or a doctor like me would prescribe to the patient and say, you have 3 days to go see this doctor? That would work. So the whole system has to come together to try to help these people. One person cannot do it. I can only take so many patients.
Could that work, say, under a state or national controlled medical system, healthcare system, as almost every other country has? We are so fragmented in this country between what is locally controlled, what is state controlled, and what is federally controlled, and insurance versus, private versus public. Other countries with a completely public system, would this kind of thing work better?
Okay, so let me answer this question comparing America versus Canada first.
Hmm.
Everybody has insurance in Canada, but the quality and access to care is not as user friendly. a lot of Canadians come to America to get surgeries done because even for a heart surgery, they may have to wait a year or two. So we know from the medical standpoint, the care is not as efficient. That's one issue. Now, we had a Harrison Narcotic Tax Act in 1914 that was put in place in America to control the trade of illegal drugs. And it said addiction is a moral failing. An addicted patient cannot get another addictive drug. See what happens. So that law is not Canadian. So Canada care to addiction is more compassionate and easily available, but their outcomes are not necessarily any better. Mm-hmm. Their rate of overdose deaths and complications is the same as ours. So even though the access to care is better and compassionate, their outcomes are as poor. So here, all the laws that have been passed after the 1914 Harrison Narcotic Tax Act are based on that law. So all these new laws that were passed, 500 laws in the last decade or 2 decades, are faulty because of that thing. So if we can either reschedule buprenorphine from a class 3 drug to a commodity drug like for diabetes, hypertension, all these problems will go away. People will have access to care. But the government made a wrong decision 25 years ago to classify as a restricted drug. And then in 2005, they criminalized the treatment arm by putting more whistles and controls. As the OxyContin abuse was going up, the buprenorphine was restricted to have access for the patients. So we went in 2 wrong directions.
And just to clarify, which I should have done earlier, when you talk about a scheduled drug, what exactly does that mean?
So when scheduled drugs are restricted drugs, so they're classified from 1, 2, 3, 4, and 5. 5 is the least abusive and addictive, but has some use. And as the numbers decrease from 4 to 3 to 2 to 1, their abuse potential increases, risk of overdose deaths increases, complication increases, and the usefulness could be in class 1 drug is none there. So like morphine is class 2 drug, OxyContin is class 2 drug, amphetamine is class 2 drug. So these are useful drugs, but they're riskier. Mm-hmm. As compared to the non-scheduled drugs, which are like for diabetes and hypertension or any other neurological conditions, they are not restricted. So there are higher regulations to prescribe restricted drugs today than there were 30 years ago.
Okay. Let me go back to the chronic pain issue. If a person doesn't want to get off the drugs and they have been told you're going to go and you're going to get treatment and you've got to deal with this, but the person really doesn't want to get off the drugs, can you do anything with that person?
Well, so the new thinking is self-help is the best help. You get up and move around. You do stretching, you do yoga, you do physical therapy. Now, anybody that comes with pain has restricted range of motion, we send them for physical therapy. Some people go to the chiropractors. Okay, but physical therapy is the way to go. And they do some corrections and then they teach you how to do the exercises at home. There are doctors who will write pain pills, like I said, but nobody is treating pain optimally because the doctors come to the risk. There's another medicine, methadone, that is for the clinics that only prescribe methadone for addiction purposes, but the same methadone in lower dosages, some doctors can write for pain control. So the second scenario could be, I have a patient who was taking 200 pills of Vicodin or whatever a day, now gets nothing from someplace, is in pain and withdrawal, is not wanting to go on Suboxone because they think is something not good. So I say, okay, the second option is I'll give you a low dose of methadone will give you pain control. You will not be in withdrawal and your quality of life would be better, but I'm not going to increase the dose.
Mm.
So when you have to require to increase the dose, that becomes addictive. The So yes, there are options. People can do things for themselves, and some people just don't want even to take Tylenol or Advil or Motrin or ibuprofen, but they want the pain pills.
That doesn't make sense, but
Yeah,
I think probably in the end, anybody would look at this and say none of it makes sense. It's just, and maybe that's because you did say in the book that everybody is different.
everybody's different.
Cannot
Yes.
You cannot just say, well, this is the treatment for an addicted person for whatever reason.
Yeah, people ask me, how come you have such good success rate? What is the formula? I said the formula is you got to know each person individually, their circumstances, psychosocial, family, environmental, work, insurance, secondary gains, tertiary losses, whatever the things are. So you have to know the patient as a whole and then sit down and talk to them and then help them out.
It's funny. You said in the book that you've had to learn something about psychology in order to treat patients, and yet you're not obviously a trained psychologist. That would seem obvious to me if I just go to my GP, my primary care doctor, that there's a whole lot of knowledge about how people, for want of a better term, work
Hmm.
in almost all kinds of medicine, and that anybody just thinks it's just about prescribing for a specific issue is crazy. And
It
that you
is.
have to actually say that in the book. I always assumed, of course, a doctor should know something about how people operate.
Yeah. Um, so 30 some years ago, I was asked a question of is medicine more science or more art? And I told myself, I said, I cannot draw a straight line. I cannot draw a perfect circle. So medicine cannot be art. You have to learn the science. But very soon after that, I started thinking that way. How you practice medicine is art. And that's what I try to uh, practice and follow in my heart, in my practice. Um, I was giving a lecture to a university program 4 or 5 years ago, just as COVID was starting, medical schools, residents, and fellows and stuff. And I thought, what should I tell them differently? And I said, medicine has become more regulations. After you learn the science, you may not learn the art. If you are good in computers, you could be the biggest BS guy in town. And if you can follow the instructions, you could be the best doctor on earth. Once you follow the regulations and you play the game that the system wants, with the artificial intelligence, it's going to be even more easier for what I'm saying.
Mm.
So uh, it's not cookie cutter. It's not one size fits all.
Well, that seems like an obvious thing, but it obviously isn't.
Mhm.
um, okay, this gets me to the reason you wrote the book. You really want to help addicted people for whatever reason they come to you, and you want to do it on a wider basis. So you wrote this book. It became a bestseller. Like I said, I would assign it to people in college, no matter whether they're specialists in medicine or not, just to get a sense of the overall, because you've done such a good job of telling us historically how this situation we're in now got to this point,
Thank you.
and also what you can do about it. You started a nonprofit organization in an effort to, I guess, go wider with your views. What's happened to that? I mean, it's just kind of in the beginnings. What's happened to that? What do you plan to do with that? Because when you look on your website and it says donate to it, It doesn't have a profile of the the organization. It's just kind of an organization.
So I'm a doctor who was trained, 40 some years ago, have no access to technology like you have with your husband. I used to write on a paper and pen and my prescriptions and charts. Now we have to deal with all this stuff. So somebody created this website and now nothing was happening. So there's nobody around me to help me and support me. I've not collected a dime on my PayPal account from this website. That's true. So it was created. And in the beginning, it was created because nobody wanted to publish my book. So my friends suggested that let's create a foundation. You don't need the money to live off it. And so I said, okay, that makes sense. So we created a RAOE foundation, but that IRS put it as private, means I got my money. I want to spend it. I could not collect any money. I spent 2 years with the IRS trying to get it fixed. Finally, we decided it's a no-go. So we shut it down. It still exists on the website, and I have to figure out how to shut it down. So then we started with another foundation called SOS, Serious Opioid Solutions. And again, I'm trying to do my best, speaking, giving lectures. I've done thousands of lectures all over the country, and some in Canada and some in India. So it's time consuming. It's very costly to try to reach the media, the policymakers, the public, somebody who has common sense. And I need to broaden the base so that more people like you join me so that we can reach more places. That's the goal. The goal is to reduce the overdose deaths, improve access to care, better education to all the doctors, and promote some common sense that, hey, people don't need to die because they have a bad situation at hand. If we are, as doctors, trained to take care of them on a longitudinal basis, long-term basis, people will do very well. And my practice and my patients is a living example. And my love and affection for them and there for me is the reason I wrote the book, because they're doing very well. And so we can expand that to a bigger level if more doctors are willing to learn and practice addiction medicine. And if the stigma goes away, stigma is a big problem in this space, and that has to change also. So I write things about how to reduce stigma, but nothing is changing much.
Well, I commend you for what you're trying to do, and I truly hope you're successful at it. You at least light a small fire that perhaps will spread.
I was hoping that once the book came out, things will change, and I didn't see a whole lot of reaction. So I started talking to some academic friends, and they said, Doc, it takes a lifetime to bring a change. So you may not see in your lifetime, but it may take 20, 30 years. So then I said, okay, fine. If it's not going to happen in my lifetime, that's fine. At least I have a little peace of mind, but I'm not giving up. My kids are doing well. My grandkids are doing well. It's not an issue as a doctor, as a human being. I think 300-400 young, healthy Americans are dying every day. It's not acceptable to me as a doctor or as a human being.
And it shouldn't be acceptable to the society as a whole either.
Yeah.
It is my sense as a journalist, as a lifetime journalist, that there never is just one solution to anything. Yours is a good solution, a good beginning to something, probably will lead to more and more. But I tend to agree with your friends. It will take time.
Thank you.
Thank you, Arun.
Have a good afternoon.
Dr. Arun Gupta, who has practiced for 3 decades in mostly rural Monroe, Michigan. Much of that time as an addiction specialist. I put a link to his very useful book about addiction in the show notes. In my next podcast, that would be episode 33, my guest will be another doctor who has started a company to help older people in various stages of dementia, including Alzheimer's, stay in their own homes. Dr. Arun Gupta's Tembo Health is working with a pilot Medicare program called Guide, which plans out medical care and helps support caregivers. Look for episode 33 to drop on the third Tuesday in May because, as you know, I schedule one new podcast a month. Please do subscribe and share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. I'm Stephanie Shelton. Take care of yourselves and those you love. Until we meet again. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.